Hi guys, welcome back to my channel. Thank you for watching this video. A lot of my friends have been asking me tips to prepare for OSCE. I think the first thing you need to be familiar with is the OSCE handbook, which you can find in the NMBA website. I will leave the link below. When you actually go through the handbook, there is a section where it talks about what you might be required to use. And those are the charts. When you go through your OSCE, you would be required to use at least one or even multiple charts. So the first chart that I'm going to show you today is the adult observation chart. And in the handbook, there's a link. If you click there, it will take you to this chart, which is the rapid deterioration observation chart. So I want to talk you through that, because I think it's really important for you to become familiar with these charts, with this chart and the other charts that I'm going to show you today, so that you don't feel overwhelmed on the day of your examination. I remember when I was doing my bridging course, the first day of clinical placement, I saw the chart and it was pretty overwhelming because I am not used to those charts, and at first glance it seems like there's a lot of information in there and it's color-coded, so it can be quite overwhelming. So I thought we will go through this chart just to get you familiar with the type of charts that are used, so that on the day of your examination you already know what the chart's for, what to look for where, and not waste some valuable times. Alright, now let's have a look at the first chart. So the first chart we're going to look at today is the Rapid Detection and Response Adult Observation chart. Up here on the right hand corner, you've got the patient details. You've got the UR number, which is the unit record number. You got the patient surname or family name, given name, second given name or middle name, date of birth, and sex or gender of the patient. Section A here gives you a general instruction of how to fill the chart out. Okay, so the minimum set of observation required, and it tells you how to fill out the chart by placing a dot. So you can go through that in your own time. Just before we move ahead, for systolic blood pressure, it tells you to use the symbol indicated on the chart, which is this one here on the side. See, it's not a dot. It's an up and down arrow. That's to denote the systolic blood pressure and the diastolic blood pressure, and that's how you would chart a blood pressure. Okay? And coming down to the next section here is modifications. It tells you who can do a modification, how long, and what are the requirements. I will talk you through it in details when we get to the section. And the next section, it says here, changes to usual frequency of observation. If you are required to do more frequent observation on the patient, or maybe just once a day, depending on the condition of the patient. For example, sometimes if a patient is going through the end-of-life stage and terminal phase, and sometimes the doctors might say, well, there's no point in doing observations every 4 hours, then they might request for less disturbance to the patient, so you might only do once a day. And down here it says intervention and review. We will go through it in section F, how to fill it out and what it's all about. Section B talks about the resus plan, 7-step pathway. I'll leave a link down below for you to go through the 7-step pathway for resus and the advanced care directives. I'd just like to remind everybody here in Australia, when you go to a patient's medical record, always check, is there an advanced care directive in place? Because sometimes there will be an advanced care directive in place where the patients might say that, they don't want to be resuscitated. So the family will sign the not for a resus form, giving their consent for not to give resuscitation, not to provide resuscitation. So those are the things that you need to be aware of. So let's go to the next page, which is section C. Up here, this is the main observation chart where you'd record the respiratory rate, oxygen saturation, oxygen flow rate if your patient is on oxygen supplement, and what sort of delivery method is being used, if it's a nasal prong, Hudson mask, whatever, or are they on high flow oxygen. And blood pressure, heart rate, temperature, sedation score. I'll take you through how to do the sedation assessment on the patient. The instructions given at the back of this page, so I'll take you through that. New or unexpected pain, pain score, and initial. Just another important thing, guys, in Australia, if it's not documented, it is not done, okay? So regardless of how hard you work, make sure that you document every single thing that you do for your patient in that care episode, everything that you do. Now, why do I say that? Because if something happens down the track and there is a complaint, or, God forbid that you end up in front of a coroner, you want to be able to go back to your record, your documentation, to prove that you have done the right thing by the patient, or you've done your job properly, okay? Because if it's not documented, just a hearsay, just your verbal explanation is not going to be enough. It's not going to stand. So they always look for written evidence, so make sure you document, and document. All right, now at the top of the page here, in section C, you've got the year, the date, the time, MER, MDT, and RN or RM. Now, what do they mean? If you look at the MER, which is the Medical Emergency Response, in New South Wales, it's called MET, M-E-T, Medical Emergency Team. In Australia, as a registered nurse, you will work with AINs, Assistant in Nursing, or enrolled nurses, who you will be supervising, and they will report to you. So if they go and do the observations and it falls within this yellow zone, they will come and notify you, okay? So then as an RN, you would come and redo the observation, especially if it's blood pressure, you would do with the manual blood pressure machine to make sure that your patient's okay. But if it falls within the pink area, here, that means you need to call for the team to review. MDT means multidisciplinary team. So you ask for the medical team to come and review the patient. Okay, inform them that the patient's observations are in the pink zone, and if there's something else going with the patient, obviously you'll give them an update about the patient's condition. If the patient's worried, the family's worried, or you are worried, okay, then it's for the team to review. But if the observation falls in the purple zone, that is a signal for you to trigger the medical emergency response. Medical emergency response is when your patient's deteriorating. The first and most important thing is early detection to avoid further complication to your patient and to get the best optimum health outcome for your patient. It's important that you realize and recognize early signs of deterioration. Okay, so that's why these are color-coded to help you identify when your patient is deteriorating. So usually in a room, or in a patient bedside, there will be a MER bell or activation bell. You can press that buzzer and call for a MET if you're an RN and you're worried about your patient, obviously. If you're not sure, then you can always go and talk to your nurse in charge or somebody senior just to get a second opinion. But, if you're worried, it's best not to waste time and to call for an MER. And later in the chart, I'll take you through when you can call the MER and what steps do you need to take. So let's try and chart some observations here. So if the respiratory rate is between 16 and 20, obviously then it's within the normal range. So, nothing to worry about. So you just put a dot here and that's it. But then, 4 hours later, you come back to do the obs and it falls within, say, it's 24. Then it's a bit of a concern because it's in the yellow zone. Then what you do is go quick physical examination. Is your patient hyperventilating? Do your assessment as a registered nurse. Use your clinical skills. And with the oxygen saturation, the same. You do the steps that you take if it falls in the yellow, pink, or purple zone is the same for any observations. All right. So when you do the next observation, you place a dot and then you just connect it like that. Simple. Okay, and again, as I said, oxygen flow rate is, if your patient is on nasal prong, you write NP, delivery method here. But if your patient is not on oxygen, you just write room air, RA. Blood pressure is the same. You put the down and up arrow and then you connect it with the dot. So let's say the blood pressure is 120/80. then that's how you will chart it. Okay, and then it tells you clearly here, use systolic blood pressure as trigger for response. So yes, in this case, your diastolic blood pressure is in the purple zone, but it's normal zone. Diastolic is supposed to be low, so obviously you won't call the MER call. You won't activate the medical emergency response. Okay, so you use the systolic blood pressure as a trigger, right? If your systolic blood pressure falls in 80, then it's way, way, way too low. Your patient is probably unconscious or too dizzy. All right, so always use the systolic blood pressure as a trigger for response. Then coming down here, you've got the heart rate. It's pretty much the same. Temperature. Now, sedation score. So it ranges from 0 to 3. And I'll quickly take you through it. So if you go to page 4 of this chart, down the bottom here in section H, it guides you how to do an assessment for sedation. You know, how sedated is your patient. So here it says 0 is if your patient is alert, awake, orientated when approached. No need of a stimulus to wake them up. Okay, so that's 0. 1, if your patient is easy to rouse, or if they're asleep and you talk to them and they wake up with a light touch, eye opening and eye contact, and if they're alert and awake for more than 10 seconds, that means you will score them a 1. Okay, and you would score them a 2 if your patient is easy to rouse, but difficulty staying awake. When you talk to them, they open their eyes, but then they fall asleep again or whatever. And then the stimulus you use is voice and light touch, eye opening and eye contact. They open their eyes, makes eye contact, but it's less than 10 seconds, then you would score a 2. Now you'd score a 3 when your patient is difficult to rouse, and even with pain, you give them a shoulder squeeze and they still couldn't, you still can't wake them up. They brief opening of their eyes, they just open their eyes briefly, or they didn't open at all. So in that scenario, you would score them a 3. So that's how you do an assessment on the sedation level of your patient, and then record it accordingly in this section here. So obviously, if it's falls in, if your patient scored 2, then you'd call for a team review. If your patient is 3, then you'd call for an MER call. Now, under that is the new and unexpected pain, right, yes or a no. If your patient score 2 or more yes within the hour, then you've got the guideline here in section G. It tells you need to inform the team. And obviously, but if it's something new or unexpected, most of the time there probably won't be any PRN charted, because they haven't had this pain before. So you need to inform the team depending on the severity of the pain. And obviously if the patient is worried, or if you're worried, and there are other signs of deterioration, such as your patient's complaining of pain, and they are also experiencing significant bleeding. And next is the pain score. If they are charted any pain medication, you give them the pain medication. You'd come back and reassess if the pain medication is effective or not. So again, if your patient's pain score is between 8 to 10 within 1 hour, then again you do your assessment based on the instructions that's written down here in section G. If you're worried at any stage about your patient, don't hesitate to call for a team review. If you think that the patient definitely needs MER, then don't hesitate to activate the MER, okay? Medical emergency response call. Again, here it says a patient or consumer is worried. If there's a respiratory or cardiac arrest, obviously you would straight away call the MER. If there's a threatened airway, significant bleeding, unexpected or uncontrolled seizure, and delayed MDT review for more than 30 minutes. Now, why do they say that? I'll explain. Now, when we come back to this chart, as I explained before, if the observation falls within the pink zone, it's for the team to come and review, right? Let's say, the saturation is down here. So 80, 89, 90%. And you've called for the team at 10 o'clock in the morning, and it's been 10:40 and no one has come and reviewed the patient. You've rechecked the oxygen saturation. You've warmed the fingertip up and changed the side of where you are taking the oxygen saturation, and it's not getting any better. It's more than 30 minutes and the team hasn't come and reviewed the patient. Then you are justified to call the MER, okay? Then you can call the medical emergency response call. All right, that's what it meant where it says here in section G, where it says delayed MDT review for more than 30 minutes. If you call an MER after, you waited more than 30 minutes, don't worry, no one's going to get cranky at you because you're doing the right thing by your patient. And to be honest, when you come to work as a nurse in Australia, you have to protect your registration. So regardless of whether the doctor get a bit cranky and upset because you didn't wait for them for 45 minutes, well, don't worry about them. Your first priority is the safety of your patient. Always remember that. And make sure you document the time that you call the medical team to come and review, okay? Because sometimes what will happen is they might be caught up. I'm not saying that the doctors don't want to come to review the patient. They might be caught up. But in that half an hour or more than that, let's say you wait for 40 minutes, your patient start deteriorating, then it's going to come back at you. To make sure, please, you document the time that you call the team and document the time that you call the MER to justify your actions. All right. So we were talking about this. So the action required are place an emergency call in specified location. So when you call the MER call, there's a buzzer or a button that you can press. You press that, and one of your team member, obviously the whole ward will hear when the MER response call is activated. And then if you stay with the patient, ask one of your team member to place a call. So in New South Wales, and I'm pretty sure this is standard across Australia, the emergency number in every hospital is different, okay? So, for example, where I work, it's 2222. So if my patient deteriorates and I press the med call button, which is what we call it in New South Wales, if I press the med call button, I stay with my patient and one of my team member will go and call the 2222, and the operator will answer and you say it's a med call or it's an MER call, medical emergency response call, and the ward is, let's say, 2D, orthopedic, bed number 2. So then what the operator will do is they'll send out a page to all the medical emergency response team, the doctors, the treating doctors, the consultants. So everybody that needs to be notified will be notified that there's an MER call, and everybody, literally everybody, will come rushing to the bedside to assist this patient. If your patient is unconscious, obviously you'll start your basic life support, CPR. You do all the basic life support principles, doctors ABCD. You initiate basic life support, and then, once the MER call is finished, what do you need to increase the frequency of observation post-intervention and the advice that you get from the MER team, all right? MER is something, I think in India it's kind of similar to Code Blue, I think. So the MER team will have the ICU registrar most of the time, the ICU consultant, an ICU senior nurse, MER CNC, clinical nurse consultant, all very, very highly skilled and trained people, okay, to come and assist you with the patient. So Section G gives you an explanation of when you can call the MER, when you can call for the multidisciplinary team review, okay. Again, at any time, you will always see you are worried about your patient, okay, or a patient or consumer is worried. And some of the observations, some of the physical signs, symptoms that you're getting, and what action should you be taking. And the same with the registrant or the registered midwife. Always notify your nurse unit manager if you're worried about your patient, or if you're going to call the MER call, always let them know, okay. So that's Section G. And down here is Section H, which we've already gone through. That is how to score the sedation score. Now, if you come to page 3, up the top here, you'll put the patient label, okay? And here, in Section D, it talks about modification. Now, what is modification? If you have a look here, it's a start date and time, modification, finish date and time, observation, trigger for MDT review, trigger for MER, doctor's signature, blah, blah, blah. Okay, now first things first. What is a modification? In Australia, as we talked about it in the previous section, if any observation falls in the pink line or the purple, it's for an MDT or an MER response, right? So let's take myself for example. My blood pressure is always low, okay? So when I go to hospitals and the staff, the nurses take my observations, they get really worried because my blood pressure is so low. They'll call for the team review. They do all the right things. And I used to tell them, please don't worry because this is just my baseline. This is just standard for me. This is normal for me. I don't have any other symptoms, okay? So my blood pressure usually would go down. Like the systolic sometimes would even be 90, and it would go to 60. So according to this, then it falls for a team review, right? But I tell them that it's my baseline because I don't want them to get worried. I don't have any other symptoms. I am asymptomatic. But if your patient is dizzy and their blood pressure falls here, then obviously you will call the multidisciplinary team to come and review. But in my case, because it's normal for me, what the team might then do is put a modification in place. So then what they will do, they will come, get the chart and write the date and the time and when it's supposed to finish and the observation. Okay, say it's blood pressure, so they'll put blood pressure. Trigger for the MDT review. If we look at the chart, again, if it's 90 systolic, then it's for a team review. But because it's normal for me, they might say, well, trigger for MDT review, let's say, will be 85. Okay? Anything less than 85 is then you can call for the team. Trigger for MER would then be if it's anything less than, let's say, 80. And the doctors will sign there, their print name, their designation, and a nurse will sign. Okay, let's say this. Print name would be that, and my designation would be, if RN. So it's important that this is countersigned by a nurse as an acknowledgement. Okay, because if the nurse doesn't know that there's a modification in place, when they go and do the obs, if it falls within this, then they're going to call for the team review. Okay, in order to avoid miscommunication, the doctors need to let the nurses know, and the nurse need to acknowledge that there is a modification in place for this particular patient. When we say modification, it means modification for calling criteria. What are the calling criteria? If it falls within the red zone, it's the team review. It falls within the purple zone, it's a MER, medical emergency response. But if there's a modification in place, and you do the obs and you follow the modification that's been put in place, and you make sure that it's within the time range, the start and the finish time, you're covered by that. And if something happens to your patient later, nobody can come and ask you, well, why didn't you call for the MER call? Well, then you can say, well, there's a modification in place and there was no other symptoms. Okay. Obviously, if there's a modification in place, and take my case for example again, there's a modification in place. The modification clearly says if my blood pressure is below 85, then for the team review, anything below 80 for the MER. So for example, let's say my blood pressure is 86, which is still above 85. But if I have other symptoms such as I'm dizzy, any other symptoms related to hypotension, then you can still call for the team review because your patient has other symptoms that you're concerned or that they're concerned about, then you can still call for an MDT for a team review. Okay? Or say the blood pressure is 80. Here it says anything less than 80, but if your patient have other symptoms, you can still call for the MER. This is only in place, the modification I would follow if there is no other symptoms and the patient's well, or if there's no new symptoms that you're worried about. So that's section D. That's what it meant by modification. All right. Section E, changes to usual frequency of observation, is, again, as I said, in the first page, if you look at your chart, it gives you a list of the scenarios where the observations requirement or the frequency can be changed. It says if requested by treating doctor. If you are worried about the patient, then obviously it's always better to do more frequent observations. Or sometimes you can even hook up the patient to the monitor for constant blood pressure monitoring or whatever. If your patient or family is concerned, then yes, you can increase the frequency of observation. After an intervention, such as, if the patient has a procedure, and especially after a medical emergency response call, there would be an increased frequency of observation, and until all the observations are in the normal range. And terminal phase and others. So that's what I spoke about. If someone is in their end of life phase, you don't need to do 4 hourly obs, unless if the patient is for full resus and for full ICU treatment. So yeah, you follow those instructions accordingly. So that's what it meant by change of frequency. And section F talks about intervention or review done. What it meant is, say the patient had a MDT or MER call. What was the intervention that came out of it? What did you have to do? So you put the date and the time. If someone had a MER call or a team review because of their blood sugars, whether it's hypo or hyper, then you write here frequency, increased frequency of BGLs, or if someone had a low saturation, did they put up the flow rate of the oxygen, so that whatever intervention you document them here. And also you can tick here if the MER or the MDT was because the patient or family carers were concerned. If there was a change in the patient's physical or mental state, then you can tick here as well, and then your name and your signature. So that's pretty much what this chart is all about. If something is not clear, or if you want me to talk about a particular section in details, please let me know down in the comment below. Okay, well, I would be happy to share what I can to help you guys out. Now let's go and look at the medication chart. So this is the sample of the medication chart, and they're pretty standard across Australia. Again, you would put the patient's label here, allergies. If it's nil known, you'll tick nil known allergies. If the patient have allergies, if it's any medication, you'll write the name of the medication or anything that the patient's allergic to. You'll write it here, and the type of reaction, whether it's a rash, whether it's fever, whatever, and then you'll initial it. Whoever makes this documentation will put their initial here. And this is where you will write the regular medications. So this is where the doctors will prescribe the regular medication, the date, the name of the medication, the route, oral, subcut IM, the dose, indication, prescriber signature, print your name. The doctor will have to print their name, make sure it's legible. Okay, and now here I just wrote here, for example, 10 a.m. And suppose if you gave the medication on the 25th of the 7th, 10 a.m., the date, and then you put your initials here. But if the patient refused, you'll write R. Not here, but obviously instead of signing here, you'd write R there. Or if it's not given, you'll write not given. And then you'll write in your progress note why it's not given if the patient's not there, if the patient had gone for procedure. Again, this is where all the regular medications will be charted. And here, in this section, it says the variable dose medications. So any medication, say for example, if your patient is on lithium, the lithium dose would be dependent on the blood results. So the doctors will chart what they want, how much do they want, and they'll have to chart it daily because it's a variable dose. Now here, VTE, venous thromboembolism prophylaxis, medications, especially post-op. This will be, they'll fit out what they want you to give. There's a special section for warfarin. And with warfarin, obviously, 2 people, you need 2 RNs to give it. So here, initial 1 and initial 2. So the first nurse will sign here, and the second nurse will sign here. The next page is the ones only and nurse initiated. So that's a stat order. If your patients need only a stat order of something, then the doctors will chart it here. The date, the medicine, the route, the dose, the date and time of the dose. They will write their name, signature. So given by, especially if it's an injection, 2 nurses will give. So there's one at the top here. Somebody will sign, and you will sign, or your colleague will sign down the bottom. Given time. And this area where it says pharmacy is for the pharmacist to come and check later. And under that is your telephone orders. Again, telephone orders need to be taken by 2 registered nurses. Okay, 1 to take the order and 1 to confirm the order to make sure that there's okay. This is so that we don't make any medication errors. And again, there's 2 places to sign because there's 2 nurses involved. Down here is basically for pharmacists. We don't have to do anything here. This is where they'll do medication reconciliation. That's what it's called. They will write down a list of the medications that the patient are taking or the patient took before they were presented themselves to the hospital. And in the last page here is the PRN medication. This is where all your PRNs will be charted. Again, put the patient's label, the date, the medication, the route, the dose, the frequency, and then when you give the medication, you put the date, the time, the dose, the route, and your signature. All right. So that is the medication chart, guys. So we've looked at the observation charts and the medication chart today. I hope this is helpful. So I strongly suggest that you get familiarized with these charts because you're going to be using these charts in your OSCE. All right. And that's it for today, guys. Thank you so much for watching this video. I'll see you next time. Bye.